Palliative Care, Dying with Dignity, introduced by Monica
and Sarah. Land acknowledgement. Together, let us now pause as we acknowledge the Indigenous peoples of all lands that we are on today. Let us take a moment to acknowledge the importance of the land we each call home. We do this to affirm our commitment and responsibility to improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people who call this nation home. Let us now join in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how each of us in our own way can move forward in a spirit of reconciliation and collaboration.
Understanding Dying and Death. Healthcare providers support residents with a life-limiting illness and their family members on a journey towards end of life. Therefore, it is crucial that staff members have knowledge and comfort with dying and death in order to create a space in which healing of mind and spirit is possible. Death is an inevitable outcome of being born and is a journey common to all living things. Humans, by virtue of their ability to think and reason, are aware at both a conscious and unconscious level of their eventual passing. The thought of death usually arouses a variety of anxieties.
Myth or fact? Everyone has access to good palliative care. Myth. The fact is, work still needs to be done by health services to fully integrate palliative care and ensure palliative excellence surrounded by a person-centered approach to care.
Introduction to Dying and Death. Death anxiety, historical perspectives on death, factors that impact attitudes toward death, self-care, and self-awareness.
Death anxiety, a complex phenomenon that represents the blend of many different thought processes and emotions, feeling a loneliness, separation anxiety, sadness about the eventual loss of self, anger, and despair about a situation over which we have no control, fear about the cessation of all consciousness at the moment of death, fear of the unknown, fear of death, fear of leaving loved ones behind, sadness, and guilt.
Maladaptive behaviors. Neurotic emotional responses to the prospect of dying can lead to maladaptive behaviors that interfere with the ability to cope with life. Maladaptive behaviors result from a person learning to handle challenging situations and experiences in a problematic ways. The situations and experiences can vary considerably. Obsessive compulsive disorder, hysteria, agoraphobia, panic disorder, oppositional, denial, and aggression.
Historical perspective on death. Traditional 1900 to 1950. Bodily context, death quick and frequent. Social context, community. Authority, religion. Social death follows physical death. Values, respect for the deceased, for transition, and for social mores. Modern 1950 to 1980. Bodily context, death hidden, institutionalized. Social context, publicly managed, privately felt. Authority, medicine. Social death precedes physical death. Values, dignity, privacy, independence, fighting spirit. Neo-modern, 1980 to present. Bodily context, death prolonged after a long period of chronic illness. Social context, private and publicly intertwined. Authority, self. Social death at physical death. Values, personal growth, sharing autonomy, informed choice, celebration of life.
Factors that impact attitudes towards death. Our families and peers, religion and culture, language, literature, and the arts and the media influence our attitudes toward end of life. Religious backgrounds, culture, language, literature, media, social network, financial situation, gender, and age.
Religious backgrounds. For some, death may be the end of life on the physical plane and may carry with it the fear of final judgment. For others, death may be viewed as the end of suffering and the chance for a peaceful rest in a better place where all loved ones will join together in a time. May also be a time of rest before entering into a new body and beginning life's journey again. Religious beliefs may also affect other end-of-life issues such as blood transfusion, artificial feeding and hydration, and medical assistance in dying.
Culture. In addition to religion, culture has an impact on how one views dying and death and has a significant effect on conversation, choices, and the decision-making process. In some cultures, the dying process is not to be told that he or she is dying.
Language. Language around end of life can indicate certain beliefs and attitudes towards death. Euphemisms, which are vague, such as lost or passed on, can distance the bereaved from the reality. Phrases such as kicked the bucket and keeping them alive till 7:05 may devalue and make light of the death.
Literature. Literature and the arts offer many diverse ways of considering the themes of dying, death, and bereavement. Music, opera, and novels, both fiction and nonfiction, offer us many thought-provoking opportunities to contemplate our own attitudes around end of life.
Media. The media has a great impact on attitudes towards end of life. We are constantly being informed of death with news, reports on war, assassinations, murder, accidents, and catastrophic events. Over time, such exposure may lead us to become desensitized to death. Often in movies, graphic scenes produce horror, while death on TV is frequently sanitized and unrealistically quick. Like exciting resuscitations insinuate that death can be avoided if we can just get to a hospital. In video games, portrayal of death, if often very graphic, and the characters simply come back to life in the click of a key.
Our social network, our financial situation, our gender, our age will all have an effect on the experience of end of life.
Ageism. Age discrimination is stereotyping of and discrimination against individuals or groups because of their age. It includes a set of beliefs, attitudes, norms, and values used to justify a way of looking at older people as weak, frail, and disabled. Prejudices towards the elderly may affect their access to care and how vigorously they are treated throughout the illness trajectory. Ageism may affect the autonomy of elders when caregivers go to family members for decisions instead of getting consent for treatments from a capable elder.
Self-care. As care providers and partners, we bring our knowledge and skill to the bedside, but we also bring our experiences, history, and beliefs. Taking care of our own physical, emotional, and spiritual well-being contributes to our being able to replenish ourselves from the struggles we witness. Therefore, we must balance caring for others with caring for ourselves. Not attending to self-care can lead to a sense of burnout, compassion fatigue, and a decreased ability to effectively function in your role.
Self-awareness. This is an opportunity to reflect on our thoughts, feelings, and motivations, and is an essential component of working in a therapeutic relationship. Sharing feelings about end of life with friends and colleagues and attempting to find meaning in our own existence can lead to death awareness. It allows us to be conscious of triggers for emotions and behaviors, and is an opportunity for personal growth and discovery. This helps us work with others to explore their wishes, values, and beliefs. To be effective in our work, we must be in touch with our own beliefs, issues, and biases. Self-reflection helps sharpen this focus and equips us to more thoughtfully approach our fellow human beings.
What are your thoughts and feelings about death and dying?
Please do not assume cultural practices of different ethnicities. The next few slides were added to show the different historical ways that different cultures celebrate or honor death.
Indigenous. Many indigenous cultures view death as a natural part of life. Among the Ojibwe tribe, life and death are traditionally viewed as different points on a continuum of spiritual existence. As death approaches, access to the spiritual world increases, perceptions or reports of contact of dying individuals and their deceased ancestors are not uncommon, which brings peace within. Traditional Ojibwe care tends to the palliative person physical, emotional, and spiritual suffering. An acceptance of death as a spirit's journey home as a goal. Some indigenous perform ceremonies which can include cedar bath, sacred fire, offerings of sacred medicine to the spirit, cedar, sage, sweetgrass, and tobacco, family feasts including food for creator, and a place set for the deceased.
Mexico, Dia de los Muertos, Day of the Dead, a ceremony in Mexico that is celebrated on November 1st and 2nd. The Day of the Dead is a time of celebration when families welcome back the souls of their departed loved ones. At midnight on October 31st, the gates of heaven are supposedly open for the souls of children to reunite with their families. On November 2nd, the souls of adults reunite with their families for 24 hours. It is believed that the border between the living and the dead disappears during this holiday. Vital to the celebration is the ofrenda, the altar, decorated with pictures of deceased ancestors, favorite food and drink. They are garnished with marigolds. This offering is believed to guide the ancestors' souls back to their families.
Ghana fantasy coffins. Fantasy coffins are a way to honor the life and the profession of loved ones who have passed. The coffins are constructed to represent the profession that individuals held during their lifetime. Funerals in Ghana consist of music, dancing, and dining. Fantasy coffins are carried by the pallbearers while dancing to music and wearing brightly colored clothing.
Madagascar, Famatihana. Famatihana is a celebration of the dead that happens every 5 to 7 years. Famatihana means the turning of bones and is a time when deceased loved ones are unearthed and their burial clothes are removed and replaced with fresh shrouds. The celebration exists so family members can meet their deceased relatives and strengthen familiar bonds.
Bali Nagabin. In Bali, death is a time of celebration because it is believed to be the soul's entry into reincarnation. Balinese people believe the body to have no significance except for providing a shell or temporary dwelling place for the soul. Nagabin ceremonies are a time without weeping and mourning. Families consult a spiritual advisor. Caskets are constructed as various animals. The ceremony lasts all day with the whole village to hear music and watch dancers partake in the sacred dance. Once cremated, ashes are sent out to sea to return to nature.
New Orleans Jazz Funeral. The Jazz Festival celebrates life. Mourners follow a jazz band to the church as the band plays somber music. After ceremony, the music changes to play more lively and upbeat jazz music. The upbeat music is a celebration of one life.
China King Ming. King Ming is known as Tomb Sweeping Day, a day dedicated to ancestral worship. Families visit tombs of loved ones and bring food, drinks, and money as offerings. The families sweep the tombs and remove weeds. The festival uses willow trees' branches to ward off evil spirits, branches to be placed on gates or doors to protect from wandering spirits. Families also plant willow trees by the graves. Kite flying, often lanterns tied to kites to illuminate the sky.
Japan Obon Festival. Similar to King Ming, the Obon Festival is a time of spirits. The Obon Festival is a 3-day celebration that has been observed for over 500 years. The festival originated from a Buddhist myth that told of a discipline of Buddha who were able to free his deceased mother from anguish in the afterlife by offering sacrifices. During festival, families visit graves, offer food and drink, participate in various celebratory acts such as attending carnivals and eating festival food. Traditional dances are performed to the sound of taiko.
Myth or fact? Palliative care is only for the last days and week of life. Myth. Fact, palliative care should start early when a disease is found to be serious and or life-threatening. Palliative care should start as soon as a disease is deemed to be progressive and incurable. The palliative approach to care results in better quality of life, reduced depression and anxiety, and in some cases, a longer life expectancy.
Palliative performance scale. Reliable and valid tool used for assessing a patient's functional status. Divided into 11 categories that are measured by 10% decremental stages: stable, transitional, and end of life. 5 observable parameters: degree of ambulation, ability to do activities, ability to self-care, intake and level of consciousness. Provides a framework for measuring progressive decline over the course of illness. Provides a best guess projection of length of survival. Example, suggests if the patient is moving closer to end of life, and serves as a communication tool for the team. Can act as a workload measurement tool.
Who should complete the PPS? Any regulated healthcare provider can complete the PPS. It is anticipated that in most cases, a RN or RPN will complete the PPS. All team members are responsible for observing the person carefully and identifying and reporting any changes in ambulation, activity, and evidence of disease, self-care, intake, and consciousness that would indicate a change in the PPS score. A PPS scale will be placed in the long-term care nursing station for reference.
How to use PPS. The PPS score is determined by rating horizontally at each level to find the best fit for the resident. Leftward columns are stronger determinants, thereby taking precedence over others. 1. Begin at the left column until the appropriate ambulation level is found. 2. Read across to the next column until the correct activity, evidence of disease is located. 3. Read across to the self-care column, intake and conscious level columns before assigning the PPS score to the resident.
Ambulation. Reduced ambulation occurs at PPS 70% and 60%. The difference between 70% and 60% is related to the activity columns. That is whether the resident is unable to do work 70% or unable to do hobbies or housework 60%. Also note that the resident at 60% requires occasional assistance with self-care. There are subtle differences between mainly sit, lie, and mainly sit in bed. The difference is related to items in the self-care and intake columns. Use these adjacent columns to help decide. As well, the difference between mainly sit, lie, and mainly in bed is proportionate to the amount of time the resident is able to sit up versus the need to lie down.
PPS activity and evidence of disease. Some, significant, and extensive. Disease refer to physical and investigative evidence showing degree of disease progression. Example, breast cancer. Local recurrent, some disease. 1 or 2 metastases, significant disease. Multiple metastases, extensive disease. The extent of the disease is also judged in the context of the patient's ability to maintain work, hobbies, and activities. For example, reduced activity may mean playing 9 holes of golf instead of 18, or continuing with morning walks, but at a reduced distance.
Self-care. Occasional assistance. Most of the time, the patient can transfer, walk, wash, toilet, eat own meals, but sometimes needs help. Example, once a day or a few times a week. Considerable assistance. Regularly every day, the patient needs help. Example, to get to the bathroom but can brush own teeth. Needs food, cut, but can feed self. Mainly assistance. This is an extension of the considerable assistance category. Example, patient needs help getting to the bathroom and washing. Total care. The patient is unable to eat, toilet, or do any self-care without help.
PPS intake. Normal refers to residents' usual eating habits while healthy. Reduced, a reduction of the resident's normal eating habits. Minimal, very small amounts, usually pureed or liquid, which are well below nutritional substance.
Conscious level. Full consciousness, full alertness, orientation, good cognitive abilities, confusion, presence of delirium or dementia, and a reduced level of consciousness, which may be mild, moderate, or severe. Drowsiness may be due to fatigue, drug side effects, delirium, closeness to death, coma, absence of response to verbal or physical stimuli, depth of coma may fluctuate.
PPS making best fit decisions. Only use the PPS in 10% increments. Example, cannot score 45%. Sometimes 1 or 2 columns seem easily placed at one level, but 1 or 2 columns seem better at a higher or lower levels. In these cases, use your clinical judgment and the leftward dominance rule to determine a more accurate score.
Case study number 1. The resident spent the majority of the day sitting in bed or lying down due to fatigue from advanced disease. She requires a considerable assistance to walk even short distances. She is fully conscious. She has a good nutritional intake. What is the resident's PPS score? %50.
Case study 2. The resident is very weak and remains in a chair a couple hours a day. The rest of the time he's in bed. He has advanced disease and is requiring almost complete assistance with self-care and feeding. He is experiencing decreased food intake with a few small snacks that remain mostly unfinished. He has adequate fluid intake. The resident is drowsy but not confused. What is the resident's PPS score? 40%.
Case study number 3. The resident is up and about on her own. She has experienced a recent reoccurrence of disease. She can do household chores with adequate rest periods. The resident requires occasional assistance with self-care whereby her caregiver watches her get in and out of the shower. Her intake is reduced from normal but still adequate. The resident is fully conscious but with no confusion. What is the resident's PPS score? 70%.
Approaching death. When a person enters the final stage of the dying process on the physical plane, the body begins the final process of shutting down, which will end when all physical changes that are not medical emergencies requiring invasive interventions. These physical changes are normal, natural ways the body prepares itself to stop, and the most appropriate kinds of responses are comfort-enhancing measures. The other dynamic of the dying process is at work on the emotional spiritual plane and is a different kind of process. The spirit of the dying person begins the final process of release from the body, its immediate environment, and all attachments. This release also tends to follow its own priorities, which may include the resolution of whatever is unfinished, permission to let go from family members.
Signs and symptoms. The following signs and symptoms are indicative of how the body prepares itself for the final stage of life: coolness, sleeping, disorientation, incontinence, congestion, restlessness, urine decrease, fluid and food decrease, vision-like experiences, and delirium.
Coolness. The person's hands and arms, feet, and legs may be increasingly cool to the touch, and at the same time, the color of the skin may change. This is normal indication that the circulation of blood is decreasing to the body's extremities and being reserved for the most vital organs. Keep the person warm with a blanket, but do not use one that is electric.
Sleeping. The person may spend an increasing amount of time sleeping and appear to be uncommunicative or unresponsive, and at times be difficult to arouse. This normal change is due to in part to changes in the metabolism of the body. Do not talk about the person in the person's presence. Speak to him or her as you normally would, even though there may be no response. Never assume the person cannot hear. Hearing is the last of the senses to be lost.
Disorientation. The person may seem to be confused about time, place, and identity of people surrounding him or her, including close and familiar people. This is also due to part to the metabolism changes. Identify yourself by name before you speak, rather than ask the person to guess who you are.
Incontinence. Someone who typically is incontinent may lose control of urine and/or bowel matter as the muscles in that area begin to relax.
Myth or fact? Starting palliative care means the person is dying immediately. Myth. Fact. Starting palliative care early means more time with a better quality of life and engaging in important discussions or end-of-life wishes.
Congestion. The person may have gurgling sounds coming from their chest as though marbles were rolling inside. These sounds may become very loud. This normal change is due to the decrease of fluid intake and an inability to cough up normal secretions. The sound of the congestion does not indicate the onset of severe or new pain.
Restlessness. The person may make restless and repetitive motions, such as pulling at the bed linen or disrobing. This often happens and is due in part to the decrease in oxygen circulating to the brain and metabolism changes.
Urine decreased. The person's urine output normally decreases and may become tea-colored, referred to as concentrated urine. This is due to the decreased fluid intake as well as decrease in circulation through the kidneys.
Fluid and food decrease. The person may have a decrease in appetite and thirst, wanting little or no food or fluid. The body will naturally begin to conserve energy, which is expended on these tasks. Sometimes a toothache dipped in water or pineapple juice may help to keep mouth and lips moist and comfortable. Do not try to force food or fluid.
Vision-like experiences. The person may speak or claim to have spoken to persons who have already died, or to see or have seen places not presently accessible or visible to you. Do not contradict, explain away, belittle, or argue about what the person claims to have seen or heard. Just because you cannot see or hear does not mean it is not real to the person.
Delirium, a disturbance in attention and awareness. The disturbance develops over a short period of time, represents a change from baseline, and tends to fluctuate in severity. Delirium is notably different from dementia. 85% of palliative residents experience delirium in the last weeks of life. This should be considered a palliative emergency and demands prompt interventions. I watch death.
Delirium, common causes: infection, withdrawal, acute metabolic disorder, trauma, CNS pathology, hypoxia, deficiencies, endocrinopathy, acute vascular, toxins and medications, heavy metals.
Myth or fact? Starting palliative care means giving up. Myth. The fact is starting a palliative care approach means that care continues and changing the goals of care.
Dying trajectories. The gradual slant trajectory is characterized by a long, slow decline, sometimes lasting for years. 2, the steep downward slant trajectory is represented by a rapid decline toward death in which the chronic phase of the illness is either short or non-existent. 3, the peaks and valleys trajectory involves alternating periods of remission and relapse. Relapses tend to become more frequent as the illness progresses. 4, the descending plateaus trajectory involves decline followed by the restabilization. Each period of restabilization involves adjusting to a different level of functioning. The length of the time the person remains in the stable phase tends to become shorter as the illness progresses.
Let's reflect on our residents and what trajectory suits them.
Effective communication. Effective communication is critical to the process of providing palliative care, knowledge, fears, and personal beliefs of members of the healthcare team. Sympathetic pain. Others absorb the feeling of discomfort and distress of those facing death. Fear of being blamed. Some healthcare professionals lack knowledge and skill in communicating with the dying. Fear of eliciting a reaction. Fear of saying, I don't know. Fear of expressing emotions. Our own fears of illness and death. The medical hierarchy. A breakdown in communication between team members can make it difficult to respond to a person's desire for information.
The class protocol presents communication strategies that support the exchange of information in a way that centers on the person's feelings and emotions and that enables the conversation itself to be a therapeutic action. C, context or setting. L, listening skills. A, acknowledgement and exploration of emotions. S, strategy of management. S, summary.
Context, spatial arrangements ensure privacy. Body language, move and talk in an unhurried manner. Eye contact, maintain eye contact if the person is talking. Touching the person, be sensitive to the person's reaction and cultural beliefs.
Listening skills. Open questions. Frequently start with how, what, when, and avoid questions that start with why, as it may trigger defensiveness. Silence. Recognize the power of silence. A person may be experiencing emotions that are too intense to express in words, and the person may be thinking or feeling something important, and a pause might enable them to formulate words to express what they are feeling. Evident hearing. Reiterate to confirm that you have heard what was said, a way to demonstrate that you are listening. Clarifying. When you have not understood what the person means, use phrases such as, I'm sure what you meant when you said, or when you say, do you mean that? Handling time and interruptions. If an interruption is necessary, express your regret and excuse yourself from the room.
Acknowledgement of emotions. Empathetic response. If the person is expressing strong emotion, you must acknowledge the emotion or all further attempts at communication will fail. And be self-aware to not project your feelings.
Strategy of management for management. The plan of care must be something that the person will agree with and follow. Discuss within the team and family and resident, if able, for what's best for the person.
Summary. Both verbal and written communication is very important among team members in order to avoid team conflicts that will impinge on the person's well-being and palliative experience.
Myth or fact? Pain is a normal part of aging. Myth. Fact. Pain is a result of disease, process, or injury. Pain is not synonymous with aging.
Understanding pain and proper management. Depending on the disease process, a person can experience a variety of physical symptoms such as pain, vomiting, shortness of breath, constipation, and fatigue. Often as the illness progresses, the person experiences not only one but several issues and physical symptoms on a daily basis, the combination of which greatly impacts the person's quality of life.
Total pain. The term total pain, coined by Dame Cicely Saunders, the founder of the modern hospice movement, refers to complex and multiple issues and all the domains of issues associated with the illness and bereavement. Pain does not occur in isolation. It affects all those who are in contact with the person. Balfour Mount speaks of the noble task of caring for the seriously ill persona and his or her family with tough clinical science and compassion. Management of total pain calls for integrated care plans that reach for perfection in terms of managing physical symptoms and psychosocial and spiritual suffering. Skilled healthcare providers need to remember that quality of life is not dependent on the management of physical issues alone. Good pain and symptom management and an environment that promotes comfort can enable healing at a deep personal level. Few things are of more concern to the person and family at the end of life than the control of pain. People should not have to wait until the end of life to have their pain addressed.
Total pain diagram. A variety of definitions exist for pain. McCarthy and Passero define pain as being whatever the experiencing person says it is, existing whenever the experiencing person says it does. RNAO states that the pain is an unpleasant and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Ty and Feinsinger define pain as biopsychosocial event. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with that actual or potential tissue damage or described in terms of such damage.
Types of pain. There are two categories of pain, acute and chronic. Acute pain is associated with tissue damage, inflammation, a disease process that is relatively short, or a surgical procedure. Acute pain warns the person that something's wrong. Chronic pain, on the other hand, is persistent, worsening, and endures for an extended period of time, resulting in decreased function and well-being.
Types of pain: nociceptive pain resulting from stimulation of peripheral pain, visceral pain associated with the organs, and somatic superficial pain and deep pain. Neuropathic pain resulting from peripheral or central nervous system stimulation, mixed or unspecified pain, and pain due to psychological disorders.
Pain can be categorized using other terms as well, including anticipatory pain, having experienced pain in a certain situation, the person expects to have pain in a similar circumstance. This has the effect of causing fear and anxiety. Baseline pain, a constant pain state for at least half of the day. Breakthrough pain, a transitory increase in pain over and above baseline pain. This causes increased psychological distress and significant decrease in function. Incident pain, a type of breakthrough pain that results from movement or action. Example, turning in bed, sitting to standing, painful dressing changes. Remembered pain, usually never forgotten and triggered by certain events or times a day.
Components of the pain experience. Many components may drive the person's response to pain and his or her willingness to accept certain care strategies. Understanding these components will help in the provision of more individualized pain management strategies. There will always be unique expressions of pain.
Myth or fact, pain is only felt while one is awake. Myth. Fact, pain can be experienced while sleeping, hence the need for around-the-clock dosing.
Pain threshold. Pain threshold is defined as the point at which the individual feels an increasing intensity of stimuli as painful. Everyone does not perceive the same intensity of pain from the same stimuli. A person's pain threshold can be raised or lowered based on several factors.
There are many different causes and effects of pain. The following chart highlights some of the most common ones.
Supportive strategies for pain. Believe the person, conduct a thorough assessment, implement the treatment plan consented to by the person, pharmacological, non-pharmacological, monitor effectiveness of interventions, consult with the care team members if goals are not met within a predetermined time period, example 24 to 48 hours.
Myth or fact, pain can only be controlled with strong opioids. Myth. Fact, while opioids are frequently used to control pain, Non-opioid medications and non-drug therapies can also be helpful.
What are your thoughts on our current pain management?
The Dying Person's Bill of Rights. I have the right to be treated as a living human being until I die. I have the right to maintain a sense of hopefulness, however changing its focus may be. I have the right to participate in decisions concerning my care. I have the right to expect continuing medical and nursing attention, even though cure goals must be changed to comfort goals. I have the right not to die alone. I have the right to be free from pain. I have the right to have my questions answered honestly. I have the right not to be deceived. I have the right to have help from and for my family in accepting my death. I have the right to die in peace and dignity. I have the right to retain my individuality and not be judged for my decisions, which may be contrary to beliefs of others. I have the right to be cared for by caring, sensitive, knowledgeable people who will attempt to understand my needs and will be able to gain some satisfaction in helping me face my death.
How to care for a palliative resident. Use a palliative approach, hope, options, support, peace, individualized, compassionate, end of life.
Integrate what matters most to the person into routine care. Music, aromatherapy, dressed in their preferred clothes, cedar bath and smudging, free from odor, scented body lotion or deodorant, comfortable bed linen, religious tokens nearby, hair tidy.
Skincare, reposition at least every 2 hours to reduce the risk of skin breakdown. Ensure skin is clean, dry, and protected from pressure, friction, and shearing. Frequently moisturize skin and apply lip balm.
Oral care. Some of the medication used for comfort may also cause dry mouth. Mouth care products may be used to help with this symptom. It helps to do mouth care often. Soften bristles of a soft toothbrush with hot water. Brush with toothpaste and water. If mouth is tender or inflamed, consider using a moistened washcloth or gauze or oral swab. Using a toothette to help with mouth care, dip in the water, squeeze out extra moisture before you use it in the mouth, along the cheeks and over the tongue. May use mouthwash or pineapple juice with toothette. Encourage resident to go denture-free as much as possible.
Environment. Ensure the room is clean and organized. Chairs for loved ones, palliative care basket, free from odor and excessive waste, calm and quiet preferred.
Summary. Key points. Understanding death and dying, myths and facts, culture differences for end of life, palliative performance scale, approaching death, communication, pain and proper management, dying person's bill of rights, palliative care approach. We appreciate you taking the time to open your mind to new death practices as well as implement common practice. Please feel free to ask questions.
And resources. Thank you for listening.